Hi, this is Amy Stanwood, and I'm going to talk to you about the clinical management of type 2 diabetes today. The first slide talks about the type of diabetes and why it matters. When you're seeing patients with diabetes, you may have inherited this patient from another provider. They may have had diabetes for years, and I think it's really important to differentiate what type of diabetes they have because it'll really help you know whether or not you can use some of the newer agents in treatment. If you've got a patient that's been on insulin for 20 years, it doesn't mean that that patient is a type 1 diabetic and might not be able to benefit from these treatments. So let me explain this a little further. When you're seeing a diabetic for the first time, I think it's really important to get a history of when they were diagnosed and how they were diagnosed. So did they ever have true diabetic ketoacidosis? Typically, if they did, that's usually a sign of a type 1 diabetic. One of the things I find really helpful is getting a history and asking them, what medication were they initially started on? So in many situations, a diabetic will be started on metformin, and then they may be on metformin for years, and then more medications are added, and then they progress to insulin. That is usually a type 2 diabetic. But if you've got a patient who says, I started on metformin, it never controlled my blood sugars, I was off of it within a couple of months, then that patient probably truly has type 1 diabetes. So how can you tell for sure? Well, there are some tests that we do that can sometimes help us determine whether or not a patient makes insulin. So remember, if they make insulin, we can use some of the agents I'm going to be talking about soon. A C-peptide is a test that determines how much insulin the pancreas is making essentially. Typically, it needs to be drawn with a glucose. And the reason why is C-peptide, if the pancreas is not making insulin, your C-peptide will be 0 or very low. But if your glucose is really low, your pancreas doesn't need to make C-peptide. So there's no reason for it to be producing. So you're going to have you can't really interpret that number. You want to kind of push the pancreas to spit out insulin, and that's why we really want a glucose above 170. I don't order any special glucose solution. I just tell my patient, do me a favor, I want to go get a C-peptide, and I'd really like your glucose to try to be between 170 and 250, and they can usually figure out how to do that. GAD antibodies are another antibody that I will often draw. Basically, they're diabetes-associated antibodies, and when these are present, they instruct the immune system to destroy the insulin-producing cells. Now, just because GAD is positive or negative, if it's positive, it doesn't for sure say you have type 1 diabetes. The C-peptide, again, will tell you if the pancreas is making insulin. But as everything goes, the pancreas could be in the process of failing and just hasn't failed, so you might still have some C-peptide present. So essentially, type 1 diabetes or lack of insulin production is when there's no C-peptide being made by the pancreas, and type 2, you will see C-peptide. So let me show you this chart here. This is a patient that I saw, and what you can see is this is one of my very well-controlled diabetics. Sometimes when I see people with diabetes where it's always so well controlled, it makes me actually think that maybe their pancreas works, because sometimes the pancreas is too sometimes the diabetes is so well controlled that it really takes a pancreas that makes insulin to get that kind of control. So what you can see here in this slide is that the glucose is 250. So this is somebody that I asked to run their blood sugar high for the test. And you can see here that the C-peptide, I'm going to just grab my little pointer. So the C-peptide right here is less than 0.1. So that pancreas, even though the glucose is stimulated, that pancreas is not making anything. The GAD is also positive, so we've got a very clear-cut type 1 picture here. And in this patient, I actually had to do this test because I needed to make sure he met criteria for pump where I work. But anyway, so that is a pretty good example of looking at a classic type 1 diabetic. One of the things I want to talk about is prediabetes. I think we kind of forget about prediabetes, but what is really important to understand, and I think this slide displays it, is that prediabetes is a continuum of this cardiorenal metabolic risk. We've really started talking about this, when we're dealing with diabetics, that everything we're doing is trying to pick agents or pick things that really help focus on ensuring that they're cardiac protective and kidney protective. So over here, what you can see is in this slide here, we've got our pre-diabetes glucose ranges, and it'll talk to you. You can just read the slide and see that if you're using an A1C less than 5.7 is considered normal, no diabetes. If it's between 5.7 and 6.5, that's considered pre-diabetes. If you're using a 2-hour glucose, less than 140 is normal, but 140 to 200 is pre-diabetes, and anything over 200 is diabetes. And then here on a fasting glucose, you can see it's less than 100 is normal, 100 and 126 is pre-diabetes, and anything above 126 is diabetes. And then what is really important to know is that people with pre-diabetes are at risk of kidney disease and heart failure. And the risk of progression to type 2 increases as diabetes advances. So it's a really important stage to educate your patients. Some of the things that we talk about is, really trying to implement lifestyle intervention for all, work on cardiovascular therapies, making sure their blood pressure is controlled. Any weight loss interventions you can use. There's a few options these days that really help patients lose weight. And then, considering metformin or low dose PO or an SGLT2 or something like that. But, you really want to, at this stage of prediabetes, remind people that if you can take them from prediabetes back to no diabetes through lifestyle changes, you can reduce their risk of becoming full-blown diabetic by almost 50% if they can continue the implementation of that. When I'm dealing with a patient with diabetes, every time a patient comes in, you don't want to assume their A1C target is less than 7. I used to, when I was very early into my endocrine nurse practitioner career, I remember a primary care provider just yelling at me because I didn't have somebody's A1C below 7. And one of the things that's really important to realize is that not everybody has an A1C goal of 7. And so when you're seeing your diabetic, I want you to think, okay, what kind of diabetes does this patient have, and what is their A1C goal? And one of the things that's going to really help you sort this out is looking at a chart like this. So in somebody who's very young and has a long life expectancy, you want that person to be tighter controlled. Somebody who's newly diagnosed versus long-standing. Newly diagnosed diabetics respond to newer agents really well without as much of a risk of hypoglycemia. If you've got a really frail patient who, if you push them too low, they're gonna have a hypoglycemic event and fall and break a hip, that is not a good management plan. So what you're thinking about is that I would say most people should have an A1C under 9, because when they're above 9, they just don't feel good, they're losing weight, they're dehydrated. But in terms of that area in between, like I had a patient with Lou Gehrig's disease, and my goal isn't to make his diabetes awful because his life expectancy is probably less than 5 years, but I don't want him to be miserable. So sometimes I say, we just push your blood sugars down until you're comfortable or something like that. So in a lot of people, you're going to have these good A1C goals like 7, 7.5, less than 8, but don't forget that you don't have to run your older, higher morbidity patients with super tight control. All right, so some treatment considerations. I'm jumping right into the SGLT2s and the GLP-1 receptor agonists because if you are not familiar with these, you need to understand them. When we look at the SGLT2 inhibitors, we know that the data regarding cardiovascular death is important, and there is a 17 to 38% reduction in CV death. And in CV death, MI or stroke, apologize, that's supposed to say 14 to 17% reduction. In our GLP-1 receptor agonists, cardiovascular death, MI or stroke, 13 to 26% reduction. These are agents that we are putting as many people on as possible. So let's start with the GLP-1 receptor agonist. At the time of this recording, there are 7 that have been approved for FDA treatment of type 2 diabetes in the US, but only 3 of them have proven cardiovascular benefits in terms of reducing morbidity and mortality. My favorite, and the one my institution uses all the time, is semaglutide, otherwise known as Ozempic. But you can see here, Ozempic has these significant 26 and 21% reduction respectively in 3-component MACE in terms of cardiovascular death, non-fatal MI, or non-fatal stroke. Victoza, which is also a good drug, has a 13% reduction in CV death, non-fatal MI, or stroke. And Tanzium or albiglutide, a 22% reduction in CV death, non-fatal MI, or stroke. So not only are these drugs great at lowering blood sugars, they're also really good at cardiovascular and renal protection. The other big benefit of GLP-1s, and I got to tell you, again, at the time of this recording, there was a national shortage of Ozempic because so many people are losing weight on it. And in all the years I've been doing endocrine, we have not had drugs that work so well on weight. So as you can see here, when you look at semaglutide versus placebo and up to 68 weeks post starting of semaglutide, weight reduction is just pretty significant. And in some cases, we get anywhere from 15%, even more percent weight of total body weight loss lost with these medications. SGLT2 inhibitors are being called the new statins, and the reason why is so I apologize, I'm not really going into what SGLT2 inhibitors are, but just be sure and look that up if you're not familiar with them. There are 4 that are approved in the US, and basically these medications work by allowing your kidneys to spill extra glucose into their urine. So the 4 that have been approved in the US are listed here. There are 3 of them that show reduction in CV death. And, specifically the one I use, empagliflozin or Jardiance, is our big one that we use at our institution. And, what you're going to do as a provider is you're going to find drugs that the data behind, and you kind of pick one and stick with it. And that's what I've done with my SGLT2 inhibitors, is I really have sort of used a lot of Jardiance or empagliflozin. So the big EMPA-REG trial showed a 38% reduction in cardiovascular death when adding this on to the regimen. Now, SGLT2 inhibitors are their mechanism of action is actually preload reduction, afterload reduction, and decreased sympathetic outflow. So they enhance urinary glucose excretion. So you get about 400 calories of glucose lost in the urine, so these people will get weight loss as well. It kind of is the effect is sort of a natriuresis. There's an intravascular volume contraction, a blood pressure reduction. So you want to make sure if you're giving this to your frail patients that you're telling them to watch for dizziness. You do see weight reduction, not nearly as much as the GLP-1, but you certainly do see it. And then a reduction in A1C. And I think you can get anywhere from 1 to 2% with these medications, depending on if you get that weight loss with it. So the SGLT2 inhibitors, when we look at the data in terms of the benefits beyond CV death, MI, or stroke, heart failure reduction is a big thing. The dapagliflozin trial showed that there was a 30% reduction in heart failure events, an 18% reduction in cardiovascular death, and a 25% reduction in hospitalization. And the EMPA-REG trial showed a 25% reduction in CV death or hospitalization for heart failure. So these are drugs that we are giving to our heart failure patients, to our cardiac patients, to our kidney patients. If you look here in renal failure, There was a decrease in intraglomerular pressure. That's essentially the main mechanism of action. And then we talked about, the getting rid of glucose. The patients in the clinical trials that really benefited in terms of kidney disease were patients that had proteinuria. There was such a significant reduction in proteinuria and actually time to dialysis, pushing dialysis away, that the kidney docs at our institution are giving them to as many people as they can. You can't technically give it to people with an eGFR below 30. We push it in specialty, and I think the renal docs go even down as far as 20. But in primary care medicine, you're probably going to want to stay at 30. And then atrial fibrillation in the DAPA trial, there was a 19% reduction of new onset AFib. Tirzepatide is a medication that I have not gotten to use yet, and I'm really sad, but we just don't have it on formulary at my institution. But basically, this is a combination of a GLP-1 and a glucose-independent insulinotropic polypeptide, or otherwise known as GIP. So these GLP and GIP drive the incretin effect, and this leads to insulin release and postprandial glucose clearance. The biggest thing we see with tirzepatide is weight loss, and there was a trial that looked at 15 milligrams compared to Sema 1 milligram, which is the drug I told you I just love. There was a 25% weight reduction versus like 13 to 15 with Sema. This is equivalent to bariatric surgery. If you see that kind of a weight loss with your patient, that is phenomenal. So I'm really excited to use it. Haven't had the chance, but I think we'll be getting it soon. And then they also saw a 2.3% reduction in A1C compared with 1.9 with Sema. So both of these drugs are great. I'm super excited about diabetes management. It has just changed so much in my 20 years. Okay, so let's talk about anti-hyperglycemic therapy. So with any diabetic, the first thing you want to do is implement lifestyle therapy, as you see right here. The next thing you want to do is look to see, does your patient have anything in these categories that you want to reduce? So if your patient has coronary artery disease, you should be looking at a long-acting GLP-1 receptor agonist as your first drug of choice, even before metformin in some of these patients. And then look at an SGLT2, because if you look, these drugs in green, they have proven benefits in cardiovascular reduction. If you've got a patient with heart failure, whether it's with a preserved ejection fraction or not, you should be looking at an SGLT2 as one of your first lines of treatment. If you've got somebody with chronic kidney disease, you should be looking at an SGLT2 or a long-acting receptor agonist. And then if you've got somebody who's had a stroke, the recommendation is a long-acting GLP-1 receptor agonist. Pioglitazone actually has cardiac data. We forget about this drug. We don't use it very much. It does cause fluid retention and weight gain in some people. In terms of some data on PO, there is some data out there. So when you look here, we talked about A1C goals in most patients. I don't really push people too far below 7. I just don't think that many people, well, if they are not on insulin and you're using these drugs, you can easily get them below 7 or 6. I mean, we see A1Cs of 5s in some of our type 2 diabetics who have had significant weight loss with some of these injectable or oral treatments. When it comes to insulin, it's a lot harder to get diabetic control that tight without hypoglycemia. So over here, you can kind of see the recommended hierarchy in some of these patients. We're really trying to get people off insulin if we can. I mean, if they need it, they need it. And to really avoid using sulfonylureas, because there's no additional benefit in sulfonylureas other than glucose lowering. Every year, the American Diabetes Association publishes their sort of update, and you typically see one of these charts, which I find so great for teaching and things like that. And in every iteration of the guidelines, you will always see lifestyle as first line, as well as metformin. And the times have changed a little bit. So basically, metformin, generally we consider lifestyle metformin first. However, they have cardiovascular disease, going down this pathway of choosing the GLP-1 or the SGLT2, heart failure, CKD, etc., you really want to be in these class of drugs. And if your patients don't have insurance that covers it, it's just unfortunate because these drugs offer so many benefits. What's great about this chart is you can kind of go to the right here. If your goal in your patient is to minimize hypoglycemia, so let's say you've got an elderly person with type 2 diabetes, you really want to look at using either your DPP-4s. A DPP-4 agent for me is a drug that just lowers A1C a little bit. It doesn't really have any side effects. And but you don't get a ton out of it. There's not significant data in terms of cardiac protection, etc. But if you can get the GLP-1s and the SGLT2s, they just really don't cause significant hypoglycemia. And then you just kind of follow this algorithm. This is something that I would take a picture of if I was newer to managing it, because I think it will help you clinically make decisions. If minimizing weight gain or promoting weight loss is the priority, you have got to pick that that GLP-1 first. The weight loss is really awesome. SGLT2 inhibitor, in many cases, I add them both. I try not to do that on too many occasions unless I've got somebody who I really know that they're going to end up on both. And again, you can just go down this pathway. If cost is a consideration, which it is for many people, it's still not wrong to use insulin, a sulfonylurea, or a TZD. The drugs that work, they just don't give us all the additional benefits that we're now seeing. I used insulin and sulfonylureas and TZDs for years and years and years. So that's why diabetes has become so much more fun to manage, because the drugs are so much better. And then this is a chart that I put in here, and I have to try to show you how to add injectable therapy. And I'm going to sort of walk you through this a little bit. Basically, the reason I have to turn to the right is because it's bigger for me to see on this other screen. But, as it says up here, the biggest thing you want to do is try to consider a GLP-1 in most of your patients. And this chart will kind of tell you how to initiate it and titrate it. And then if you've added, you're going to have people that don't tolerate the SGLT2s because they get urinary tract infections or they're getting dizzy and dehydrated. You're going to have people that don't tolerate the GLP-1s because they're nauseous, and they just won't take it. So if you've tried everything and the A1C is still above target, this is where it's time to add 1 dose of long-acting insulin. And basically what you want to think about is that you're just trying to shove all of the blood sugars down. These insulins typically last about 24 hours, so you're just shoving all of them down. And it talks in here about, what a starting dose is. I would say in most cases, I probably start 10 units unless they're super thin. But, I don't typically go to like a big, point, what does it say here? It says 0.1 or 0.2 units per kilogram per day. I typically start with 10 units, and I give patients a fasting goal. So I like to dose my long-acting insulin at bedtime, and then I give them a blood sugar goal of less than 150, and I'll say, okay, we're going to start you at 10 units of long-acting insulin, and I want you to check your blood sugar every morning. And now I usually say every 3 days, like you have to choose a duration. So I'll say every 3 days, if your blood sugar is still above 150 in the morning, I want you to add 3 more units. Or every 2 days, I want you to add 2 units. I typically pick my days and my units so they match, just because I think patients will remember it easier. So I may say I want you to every 5 days, as long as your all 5 days average is still above 150, add 5 units. Again, it's just going to depend, but you can pick your days and units. And what'll hopefully happen is that by the time they come back to you in clinic, they will be, instead of being on 10 units, they'll be on a dose of insulin that really helps control their fasting blood sugar. And then the next thing you're going to do is, once you get that fasting blood sugar to goal, you're going to see what happens the rest of the day. Remember, this is long-acting insulin. So usually I can control overnights, which is why we dose it overnight. But if the patient doesn't have much pancreatic function to cover blood sugars during the day, so when people eat food, their blood sugar just really climbs. If they have some insulin reserve, in many cases, you can just put them on this long-acting dose of Lantus or Glargine or Degludec or whatever, and you'll shove a lot of their blood sugars down. But sometimes in the later stages of diabetes where you put them on that, you control the morning blood sugar, but then you see them climbing all day long. And the problem is we can't use a long-acting insulin to try to control food if we can't keep those blood sugars down. And that's really the first sign that you need to start adding in short-acting insulin if you've already tried the GLP-1, etc. So this chart here talks about different ways that you can add what we call prandial insulin. So basically you can start with like 4 units a day or 10% of your basal insulin dose. And, it kind of gives you some tricks based on what your A1C is. So if I've got somebody on basal insulin and I've got them on, let's say 25 units, and I just have a slight rise in their blood sugars, I may just tell them, I want you to add 4 or 5 units with your biggest meal of the day. I'm going to kind of look at their pattern if I have them on a CGM or I have some ability to see their blood sugars, and just try to work on 1 time a day. And then if a lot of times people will, their dinner will be their biggest meal. So you have them on long-acting insulin, in the background, and then you only need dinner coverage. So you say, okay, let's start with like 5 units of insulin with dinner. And then, you can really adjust that. If you're seeing that within 2 hours after dinner, their blood sugars are still high, anywhere from like 2 to 4 hours, you can continue to titrate that mealtime insulin until you see a 2 to 4 hour postprandial or post-meal blood sugar. I always say under 180. That's what my target is for a lot of my patients. So this is a really good chart that you can put in your bag of things to try to really help you, when you're in the clinical scenario and you're not sure what to add. All right, management of hypoglycemia. The reason why this is really important is because a lot of times with patients, they may have a different blood sugar goal than you have. So this diagram talks about levels of blood sugars. Some of us refer to them as mild, moderate, and severe. Essentially what it is that when you're looking at hypoglycemia in patients, some of it is inevitable, right? If you've got a younger patient who can feel their lows, and they get a little bit low because they're on, insulin, but they're feeling it, they're responding, and it's not a pattern that's occurring regularly, then that's okay. But again, when you define what your goals are for your patients, you want to make sure that you educate them about hypoglycemia. So we typically think of anything less than 70 as a low blood sugar. Now, if it's less than 54, that's considered more severe or moderate. And if it's a severe one, then it's usually not necessarily even blood sugar based, but it's characterized by altered mental status or physical functioning requiring assistance from another person. So you're passed out at work, you can't give yourself juice, somebody's trying to help you. That's more of a severe hypoglycemic event. And in these people, remember, you don't want to use the insulin or the sulfonylureas unless you absolutely have to. Or if you have them on insulin, don't set your target so low. Remember, your job is to define where you want your patient. So you may say, I want your blood sugars at 150, but in a younger guy, you may say, I really want you to push for the low hundreds. And then essentially talk to them about how to detect them. So some people don't have the traditional signs of hypoglycemia like shakiness, sweatiness, etc. I've had patients who have had weird things that help that, like for instance, they'll say my right toe gets numb, or I get numbness in my left finger when I know I'm starting to get low. So, when somebody's having a low, remind them to pay attention to this different symptoms and always check a blood sugar before getting in a car. We give patients things to treat lows, such as oral glucose tablets or sugar-rich foods. I learned from a provider years ago that they said don't give them anything they like to eat because then it encourages them to be low. So don't have them carry Skittles, but in general, just have them carry something. The big thing is that there is what we call the 15-15 rule. So one of the problems with hypoglycemia is that somebody gets a low blood sugar and it's a pretty scary experience. And the next thing that happens is they open up the fridge and eat whatever they can find. And now you're dealing with a blood sugar of 300 or 400. And so the 15-15 rule was really implemented as a way to say, tell your patients 15 grams of carbohydrates and then wait 15 minutes. And that waiting 15 minutes is really key because we need time for that sugar to get into their system. So, you want to treat with 15 grams and then wait 15 minutes. And the best thing for them to do is to have 15 grams of carbohydrate in their pocket or in a juice box. I like those little juice boxes if somebody feels the need to drink something because they're usually exactly 15 grams of carb. The problem with some of the full-size sodas is that they're a lot more than 15 grams and then people end up with a high blood sugar. So try to get them to measure something and then wait. That's going to be the real key to preventing or treating hypoglycemia. In terms of everything else, diabetes is not just blood sugar control. When you're seeing a diabetic, you really want to be looking at as much as you can. So how are their lipids? As a diabetic over 40, they are in a statin benefit group. Like essentially, what is their risk? So some things to look at. This chart, I think, lays it out very well. So essentially, when you've got somebody who has very high risk or extreme high risk of a cardiovascular disease, this target is going to tell you how low to get their LDL. So if you've got somebody that has had a second event in 2 years, we are going to try to push that LDL below 40. And that's something that we can do with some of our newer medications. So we've got statins, which will lower LDL anywhere from 30 to 60%. We've got our PCSK9 inhibitors, which is a great class of medication, and we're seeing up to 60 or more % reduction in LDL. And then we have ezetimibe, which is basically about a 20% reduction in LDL. And again, everything listed in green have been proven cardiovascular benefits in cardiovascular outcome trials. So I think this is really helpful in terms of where you want to target your cholesterol in some of your diabetics and different patients. So if I've got somebody that's got really occasionally I'll have a marathon runner or a mountain bike racer who's got type 1 diabetes and they don't want to be on statins. But they have diabetes and they're over 40 and, the data on type 1 isn't as clear, but essentially we think, if you've had type 1 diabetes for at least 10 years, then you should probably be on a statin. Sometimes in those patients, they're just not convinced. And that's where I may check an apolipo-B level, which is a atherogenic marker. So sort of another test. And if it's elevated, I'll say to them, this is another test indicating that your risk of cardiovascular disease is higher. And then sometimes that will push them over to get on a statin. In other cases, I will do a cardiac calcium score. Calcium you can get a thin cut CT through the heart, and cardiac, if there's any calcium, anything above a 0 is essentially risk. And so if they're a 0 and their ApoB is low and they're diabetic and they're training and they don't want to be on a statin, I feel more comfortable with that decision. But sometimes it really helps me kind of convince people that they do have underlying risk. The other thing I don't know that we take seriously enough is management of hypertriglyceridemia. And, there's now some data showing that the fish oil, like IPE fish oil, is sort of this highly purified form of a marine-derived omega-3 fatty acid known to reduce triglycerides. And there was a big clinical trial called the Reduce It, and by adding 4 grams of this daily resulted in a 25% reduction in cardiovascular risk event beyond statins. And so, when you've got somebody with elevated triglycerides, and typically we think anybody who's got triglycerides, our assay is 150 or above. adding some of this fish oil. If it's below 5, if I was always taught that when the triglycerides are above 500, the risk of pancreatitis is pretty high, and so you really want to essentially reduce that risk, implementing a low-fat diet, moderate carbohydrate, and then the max tolerated statin. So you can kind of look at this chart and see how to incorporate triglyceride medication. If you've got somebody on a statin or you're about to add a statin, just remember you can get 20 to 30% reduction in triglycerides just by adding a statin. So oftentimes I'll add the statin if they're below 500, if I don't have them on one, reevaluate in a month or two, and then decide whether or not I need to add more. If you've got that person with really high triglycerides, fenofibrate medication is going to lower triglycerides about 30 to 50%, and then the omega-3s 30 to 40. Niacin is supposed to help triglycerides by about 20 to 30%, but so many people can't tolerate it. You get this awful niacin rash in a lot of cases, so it's not a drug that I use regularly. And then pioglitazone, again, it works in triglycerides, it works in insulin resistance, and it can be a good drug to add. Now, if you've got somebody with acute severe hypertriglyceridemia, you can also add insulin. Insulin can be used in certain cases as a triglyceride medication, and so I've seen that happen. The way I found that out personally was I had this patient who had really good blood sugar control, and I took her off of her insulin because she was doing so well, and her triglycerides went through the roof. And then she'd had like these episodes of pancreatitis in the past, and it was insulin was kind of the key mechanism for getting her triglycerides under control. What about high blood pressure? Again, you're seeing a diabetic in clinic. You're thinking about their eyes, you're thinking about their kidneys, you're thinking about their heart, you're thinking about their blood pressure. So essentially goal blood pressure, and this always seems controversial, whether it's 130 over 80 or 140 over 80 or 140 over 90, but essentially, you want to assess the blood pressure at every office visit. And then some of the things you want to think about is that, in anybody who's got diabetes, you really want to be looking at an ACE or an ARB. We say at the max tolerated dose. And the reason why we say max tolerated dose is because in the clinical trials on a lot of these medications, it wasn't at 5 milligrams of lisinopril where they saw benefit. It was at 40 milligrams. And so if you can control the blood pressure and you can push those doses, we really want you to. And then calcium channel blockers would be second line, thiazide third, and then spironolactone fourth. So these are great choices for a diabetic. And then some tips here on orthostatic, blood pressure, etc. Just included in here a quick chart of sort of clinical tests for diabetes. I talked about a cardiac calcium score, and here you can see that was that thin cut CT that I mentioned. If you have diabetes and you are a high-risk patient, you don't need a cardiac calcium score, because if your patient's willing to take a statin and they have diabetes, you don't need to assess additional risk unless for some reason you're doing it for something else. But so if you get a cardiac calcium score and it says 0, it's really considered low risk, even in diabetes. But if you get anything above a 1, you basically see moderate to high risk depending on percentile for age and gender. If it's above 100, it's considered very high risk. And, if it's above 300, it is a significant, it's equivalent to secondary prevention as somebody already having an event. So cardiac calcium scores are great for people where they don't fit into a statin benefit group. So our diabetics are out, they're all supposed to be in one. But if you have another patient, just as a side note, who you don't assess risk, but they've got a family history, this might be something that's helpful. Carotid plaque by ultrasound, again, that's done in some clinical trials. It's not something I do traditionally unless I hear a bruit or they're having lightheadedness or dizziness. Again, you can kind of look through these. I do an annual microalbumin, and I look at kidney function every year. But the big thing I want to tell you about an annual microalbumin is that In many cases, I find it so helpful. I had a resident following me once, and he was arguing that if somebody was on an ACE inhibitor, he didn't need to do a microalbumin unless there were creatinine changes. And what I want you to remember is that a microalbumin is an early sign of protein in the urine, and that is an early sign of kidney disease. So if you had protein in your urine, wouldn't you want to know? Because you know what that might say to me if I was a diabetic is it might tell me, gosh, my kidneys are starting to show signs of disease. I need to really work on my blood sugar control. And then over time, so every year I get one, and then even if the creatinine's normal and I'm trending them and I'm saying, you know what, your protein's going up, your protein's going down, and making sure that their blood pressure's controlled, making sure I've got them on an SGLT2 inhibitor because protein in kidneys, we talked about that, and then making sure that I have them on an ACE inhibitor. But it's constant education. Just because the data may say it's not going to change what you do, in some cases, the right thing is to continue to educate your patient. I do a foot exam pretty much every office visit, just to double check. I think patients feel good about those, and I think they feel like you care when you do them. In terms of screening, so the ADA is now recommending adults without risk factors be screened for prediabetes and type 2 diabetes starting at age 35. It used to be 45. And then the new guideline also recommends that women who are planning to become pregnant, especially if there's any underlying risk factors, be screened for diabetes with a fasting glucose test. And then for unplanned pregnancies, that they be screened at the first prenatal visit. On to more screening, like I've been reiterating, we make sure that our eyes are done annually. And people tell me, my patients tell me all the time, oh yeah, I got new glasses. And I always tell them, I want you to make sure that they have looked in the back of your eyes, which I know they probably did, and you ask them every visit how your eyes look from a diabetic standpoint, because I want these patients to be aware of what's going on in their eyes, and I want them to know how often they should be going back. I don't check eyes anymore. It's a lost art, and I just don't think that I need to. I think it's really okay if as long as they're getting their annual eye exam. Kidneys, I'm getting a creatinine probably every visit within an annual microalbumin. So my visits with my diabetics, if they're really well controlled and everything's in target, I do every 6 months. My poorly controlled diabetics or patients whose parameters aren't at goal, I'm seeing every 3 months. With feet, we're talking about neuropathy, any sores, any swelling. We're talking about statins, and then trying to promote exercise if tolerated. We also talk about things, mental health is that people with poorly controlled diabetes can be severely depressed, and poorly controlled diabetes can be a component of what's going on with their mental health. And oftentimes you may ask a patient, what do you want to focus on today? Or what are your diabetic goals? And he or she may say, I don't really have any. I just don't want to be in the hospital. It might be a good time to screen for depression. Always encouraging your diabetics not to smoke. I had this one diabetic once that told me, he said he had lost both of his legs. And he said, if somebody told me that diabetes and smoking meant I would lose my legs, I would have never smoked. And he said, I had to promise to tell every patient that I ever saw after that. So anyway, no, smoking and diabetes is a really bad thing. And then really trying to limit alcohol, especially avoiding it if triglycerides are elevated. Encourage good nutrition if possible, physical activity, and sleep. I threw on here some vaccinations for people with diabetes because I just think they're important to have. We want our patients to have COVID-19, Hep B, HPV, and then you're looking at your pneumonia, your Tdap, and your zoster. And then depending on their risk factors, there's some additional things here that they may need. Okay, I know this is getting long, but we're going to talk about continuous glucose monitors. So how do they work? For those of you that don't know, a continuous glucose monitor is essentially a device that is worn on the skin and is inserted with a needle. The needle comes out and a little teeny catheter is left under the skin. So what's really important to know is that when somebody checks a finger stick, they are going to be getting capillary capillary glucose, okay? When you read a blood sugar on a CGM, so this device sits in the interstitial fluid, and it reads blood sugar, glucose, as it's passing through to the muscle cell. So if people are comparing their capillary blood sugar to their CGM, they may be different. There is a lag with CGM. And that's okay. They don't need to check both. They don't need to be double checking. It's just not, they're going to drive themselves crazy. So what's really important is that they understand that there is a little bit of a lag behind the capillary glucose when glucose is transferring into the muscle. At our facility, we have criteria. Type 1 diabetes, anybody with type 1 diabetes gets it. If we've got somebody with type 2 on MDI or multiple daily injections, they get it. Hypoglycemia and unable to get off some of those hypoglycemic agents. So remember, we're trying to get them off the glipizide and the insulin if possible. And then anybody who's pregnant or has dexterity issues. In terms of the Medicare criteria, I apologize, I should have put that in here, but it's just really important to make sure that you're putting patients on it that need it. If somebody is just on metformin, they do not need to be checking their blood sugars regularly at all, as long as they're keeping office visits with you. The data shows that when people are on oral agents that don't cause hypoglycemia, there's no difference in outcomes from an A1C standpoint from checking versus not checking. So don't throw a bunch of this equipment at people who don't need it. This is an example of what you would get from a Libre CGM. So on the market right now, we have a company called Libre, and then a company called Dexcom, and then Medtronic also makes a CGM, but the two that we use are Libre and Dexcom. And this is what is really helpful. This is what you get when you look at a Libre. You're looking at a blood sugar every 5 minutes for whatever duration you are looking at. So I typically always look at the last 2 weeks, and you're seeing more data than we have ever seen. So ironically, there's a little bit of a pattern here. It looks pretty similar, but you can see the extreme variability in blood sugar control. This is somebody that, it's a hard pattern to fix. The first technique is always trying to fix the lows. So the first thing you should do with diabetes is if somebody's having lows, let's fix those. What's interesting about this is this estimates the A1C to be 7.8%. So if you're seeing this patient and you're thinking, oh my gosh, their A1C is 7.8%, that's not too bad. You have no idea that they're having all this hypoglycemia because an A1C is an average. So if they're low half the time, their blood sugar might look good. And this is really what's beneficial when you're seeing a CGM. This is another CGM report. And I think what's really important here, so you can see here, it says the target range is 47%. And what we aim for in most of our diabetics is that they are in target, which is typically that target is 70 to 180, and that they are in target at least 70% of the time with less than 3% hypoglycemia. So in this patient, you can see the target is 47%. This patient has 10% hypoglycemia. This is not a well-controlled patient at all. And so this would be something where I'd want to look at this trend and try to figure out, you can see the lows are happening overnight. So we want to look at what's contributing to that and then try to fix these highs that are occurring after meals. This is another example. You look at this one, and what providers who are not in diabetes do a lot of the times is whenever the A1C is high, they crank up the Lantus insulin. Like, oh, I've got you on 1 dose of long-acting insulin, your A1C is still high, I'm going to give you more and more and more. And remember, Lantus or any sort of a 24-hour long-acting insulin, if you're dosing it at bedtime and you're trying to fix these blood sugars right here, you're going to keep crashing them if they're having lows overnight. And so the answer here isn't more Lantus or long-acting insulin. You actually want to decrease the long-acting insulin and figure out how to cover these highs that are happening after meals, whether it's adding mealtime insulin or whether it's adding a GLP-1 if you don't have them on one or something like that. So CGM is incredibly helpful in these situations. And Again, sorry, that was at my institution. So the last thing I want to say is I just want to remind you all about shared decision making. And this took me a very long time to learn as just as a nurse practitioner in endocrinology and somebody who manages a lot of diabetics, is that this is a really tough disease. And I think in a lot of cases, the first question you should be asking any diabetic you see in clinic is, what do you want to talk about today and what are your goals? And I started doing this versus me dictating to them and saying your A1C is too high, your blood sugars are too high. Like, now what I try to do is say, tell me what your goals for this visit are. Tell me what your goals for your diabetes are. Tell me what blood sugars you're comfortable with, and tell me what blood sugars terrify you. And the answers you get are really interesting. And then you work around that. Your goal isn't to just shove everybody below 7% with their A1C, but your job as a provider in this field is to really learn what they can do and what they're willing to, what their goals are. And I've heard everything from, I just wish that when I came into clinic, I always had the same provider. I can fix that. I just wish that that people would stop talking to me about my weight. I just wish that, I could not have any more lows. Those are kind of the things you hear. So I think in general, really talking to your diabetics about what their goals are is incredibly helpful. And that is all I have for you guys. Thank you so much for listening and joining my presentation.